Hey guys, this is Dr. Casey Hill with a real life example of before and after gait analysis for knee pain. We performed these gait analysis at Ochsner Health Clinic at the Grove in Baton Rouge. Gait analysis involves getting a thorough history of the runner with how they run and what the problems they've had and how they've tried to fix them, as well as, of course, watching the runner to see what they do when they're running. And we use the physical exam to help tell us why they do that. Combine all this to give the runner a treatment plan to try to fix their injury and improve performance whenever possible. Now that you've had some time to watch this runner in action, let's break her down a little more and see what we can find. Now, this runner here is a 40-year-old female. She had completed a really successful half marathon. This was back last summer, so almost 9 months before she saw me. And she took a little while off, and when she tried to start running again, she developed some pain in the right knee. Really couldn't get past 3 miles without the pain. She decided to take another month off and see if that helped, but it really didn't. She saw a local orthopedic surgeon near her home. Didn't get much of an answer, had an MRI. In fact, actually underwent 2 MRIs that didn't show much. Was mostly diagnosed with IT band syndrome. She tried a steroid injection that didn't help, saw a chiropractor without much help, tried physical therapy, but notes, digging into the therapy she had, it was largely focused on modalities like dry needling, some ART, cupping, Graston. She did some exercise, but was mostly at a low level. The last time she tried running before she saw me was 2 months prior, and she was only able to go just over 1 mile before the pain stopped her. So you can imagine she was pretty frustrated. She had possibly a related but probably separate injury. She was bending over to grab something in her car, felt a pop behind her knee. Really seemed pretty consistent with the hamstring strain, so that was going on as well, but wasn't actually as bad as this lateral knee pain that seemed consistent with IT band syndrome. So what problems do we see mechanically in the sagittal plane? First thing I look at is actually posture. She has a bit of a backseat type posture with a little bit of overarching in the low back there. This could be caused by a combination of weak glutes and weak core muscle. She had issues with diastasis recti after having babies, so probably a little bit of core weakness. And the other big thing we see in this frame is overstriding, with the foot landing significantly far in front of the body. One easy way to measure that is just looking at where the heel touches down, drawing a line straight up, and we see that that passes well in front of her body. Another thing to look at is what's called the foot inclination angle, how the foot hits the ground, and we can measure that angle at about 20 degrees. Anything above 10 degrees has actually been correlated with overstriding. Now, for any runner with knee pain, I really want to look at the frontal plane. And one of the things we see here is what Irene Davis refers to as a loss of knee window, as we don't see daylight between her knees here when she's at the ends of her stride. It's similar to a crossover gait pattern, which we know puts strain on the IT band. Another really big factor for her is this internal rotation that she goes into at push-off. We see here kind of the straight up and down plane. She's actually pushing off with about 20 degrees of internal rotation. The gluteus maximus is a large external rotator, so when we're seeing this much internal rotation, it tells me she's probably over-relying on the hamstring and adductors and underutilizing the gluteus muscles, which has also been associated with IT band syndrome and knee pain. So what does the Optogait actually see? Optogait is really good at measuring asymmetries that would otherwise not really be easily detectable with the naked eye. I always look at ground contact time first, and she has about a 1.7% asymmetry, and she's on the ground longer on the right side, which would usually indicate to me that she might be a little weaker, a little less power on the right side. However, when she pushes off, she actually flies farther on the right leg, and she's about 1.3% asymmetric with step length. So sometimes we get this kind of mixed pattern where the right leg is hurting, but it actually looks to be stronger. And it could be that it is stronger and the left leg's weaker. The right leg's trying to make up for it and contributing to the injury. However, regardless of that, we want to see that this asymmetry is decreasing if we're making good progress down the road. Also, we look at cadence. Cadence of 171 is not bad. How many times each how many times each foot is hitting the ground in a minute, but there is room to improve that, and we know it would probably help some of the overstriding. And then I'll look at contact phase, which in Optogait speak is how long it takes from when her heel first touches down until her whole foot is flat on the ground. I'm less worried about asymmetry here, and I'm more worried about the hard and fast numbers, because if I'm decreasing her overstriding, we should see that the contact phase numbers actually get a little faster. So how do we work on improving these things? Well, she hasn't ran in months. She's spent more time not running than running over the last 9 months or so. So we want to get her back into running following the return to run guidelines. We got to remember that pure rest only weakens the body. There's really no structure in the body that gets stronger with pure rest. Sometimes we need it to heal up, but whenever possible, we want to keep moving as much as we can, but without overdoing it. And if we're not running, she won't be able to practice the posture cues that I gave her and some of the other things I want her to work on, like cadence and posture and controlling that knee. So we're going to look at a walk jog program to really work on improving running form and less about cardio for now. And we're certainly going to advance her rehab exercises, find the appropriate level that she can do, and have her work on this at least several times a week. We've got to remember that active therapy has much more research than passive therapy for fixing problems like this. So we're going to avoid a lot of the passive things she's already tried and try to get her more active. And we're going to finally move beyond clamshells, which she had done for months without much improvement, and other low-level exercises, as she was a master of a clamshell, but it was time to move on. So one of my favorite exercises for knee pain, whether it's IT band syndrome or patellofemoral pain, is what I call the Ferber exercise. As you can see here, we're pulling a band first straight out to the side, and I'm only demonstrating 3 reps. We usually do around 8 to 12 reps, and we certainly do them on both legs. And any standing exercise gives us a chance to work on things like foot control with the toe yoga that we teach, balance, posture, core control, and keeping those hips nice and level as we strengthen that hip in a closed chain position. Once she gets the hang of the Ferber exercises, we're going to move on to a tougher one called the standing clamshell. This is a fairly high level exercise, and it might take her a few weeks before she can get to it. And you can see here we're working on balance, foot control, hip abduction, hip external rotation, core control. Every now and then I'm going almost a little too far. My right knee is thinking about dipping in. So if I was looking at a patient doing this, I would tell them to not go quite so far, or I need to squeeze my right glute a little harder to keep that knee straight. And we need to work on her gluteus maximus as well, and hip extension strength, basically posterior chain strength. Like a lot of runners, she was very quad dominant. So we introduced the chair of death squat, which is really just more of a deadlift sort of pattern, hip hinging, glute dominant squat. First with the stick on the back to make sure we're getting good spine control. Then we can take the stick away, put some body weight in front of us to be able to squat a little bit deeper. Lunges might still be fairly quad intensive, but we're going to work on knee control, not letting that knee dip in, not letting the knee go way past the toes. And once we've mastered that, we're going to learn single leg deadlift pattern, and then as soon as possible get to, double leg deadlift, Romanian type deadlifting. Then as soon as possible, we'll move to single leg deadlifting. Again, working posture, balance, core control, and certainly a lot of hip stability and hip strength. Now we mentioned overstriding. If I want to shift her stride behind her, I got to get the leg behind her. So instead of a lot of static stretching, I gave her a series of progressive eccentric hip extension exercises. This being the first one in that series, really kind of loading that back leg in a slow, controlled, and eccentric fashion to work on better hip extension ability. So here she is at 1 month follow-up. We'll see if we can spot any differences in her running now. I'll give you a second to look at that. All right, so what improvements did you spot? I believe I see some improvement in posture with a little less sway in that low back, a little more upright posture, and see pretty big improvement in the overstriding. Now when we draw that line up from where the heel hits the ground, it's actually passing through her body instead of in front of it. And to that degree, we see the foot inclination angle has also improved about 5 degrees from a 20-degree angle down to a 15-degree angle. In the frontal plane, it's tough for you to make out the numbers, but we actually had about a 5-degree improvement in internal rotation. So still significant amount of internal rotation going on, but I'll take a 5-degree improvement in 1 month time any day. That's pretty good progress. So how about objectively with our Optogait data? Previously, we saw the ground contact time was 1.7% asymmetric. Now it's only 0.3% asymmetric. Similarly, the step length improved from 1.3 to 0.3% as well. So although it's a little unexpected what we saw before with the right leg almost appearing to be stronger, at least now we're seeing more symmetry, which usually correlates to the runner doing better as well. She worked a lot on improving her cadence, and she actually got it up to 177 from 171. That's about a 4% improvement. And we do the test at the same running speed, so it's not just that she was running faster now. And we can look at contact phase to verify that she is in fact landing closer, overstriding less. And those numbers, if you remember before, they were 31 milliseconds. Now she's 25 and 26 milliseconds. So another good sign, showing about 16% improvement. Of course, what really matters most is how is our runner feeling subjectively. Well, before she was having pain walking around, going up and down stairs. That's been gone for several weeks now, so she's really happy about that. She's been able to get up to a 30-minute walk run, although it's not a lot of running for her. It's more than she's been able to do in months, and she's had no inclination of that lateral knee pain. So again, pretty thrilled with that result. She's felt the hamstring area a couple times, but only with some of our higher level exercises. But that tells me it's still an ongoing issue, and we need to direct our focus a little more towards the hamstring now, as we've made good improvement with the IT band. So moving forward, we're going to keep building capacity by slowly progressing mileage, being patient, not jumping up too quick. We want to take some baby steps forward and no steps backwards. So we'll keep working on that walk run, gradually more running, less walking. We're going to keep doing the progressive strengthening of hips and core. It's only been about 1 month, and although she already feels some really good changes, we know we haven't probably made long-term adaptation until she gets these muscles a bit stronger. And now we're going to do more work on the hamstring with both mobility focused on that area, some self-treatment that she can do to mobilize that hurt spot, and a lot of progressive strengthening. We're going to add in more weightlifting and some other body weight exercises to really target increasing load and increasing load capacity in the hamstring. So thank you for watching this video. If you'd like to have your own running analysis performed, give us a call at 225-761-5200. Again, I do these at Ochsner Medical Clinic at the Grove in Baton Rouge. And you can give me a follow on Facebook or Instagram at Dr. Kasey Hill, or Power Running / Dr. Kasey Hill on YouTube for more running related info. Thanks again, and happy running.